Good morning. We're glad to have you with us. We think we have an interesting program for you. A couple of things first. I always want to begin by thanking our sponsors this morning. Let's see, Angie. Our sponsor. There you go. We've got lots of technical issues this morning, so bear with us. Our sponsors this morning, our premier sponsor is Anthem Blue Cross Blue Shield in Maine. Our principal sponsor is Harvard Pilgrim. Today's program sponsors are Cross Insurance and Maine Health. And our series sponsors, our supporting sponsors, and Work Health, and our supporting sponsors are AmeriCare Health, Central Maine Healthcare, Martins Point, and Maine Primary Care Association. And I want to thank them all for their support. We have an interesting two-part program for you this morning. The first part of our program, we'll hear a little bit about the merger of the small individual and small group market in Maine. And the second part of our program is going to be about the effort around universal health care, both nationally and in the other states, and what's happening here in Maine. Before we go any further, just to be clear, we welcome your questions, but what we're going to ask people to do is to put them into the chat function of Zoom. And when we're finished the first part of the program, which should be roughly an hour, we will come back and run through your questions and ask our panelists for their input and answers. And then I will introduce Katie Mahoney with the U.S. Chamber, and we'll talk about universal health care. So to begin, I'd like to introduce Denise Mcdonough, who is the president of Anthem Blue Cross and Blue Shield in Maine, and she's going to give us some opening remarks. She does serve as the president of Anthem Blue Cross and Blue Shield in Maine. In this role, she is responsible for the management of Anthem's local commercial group and individual businesses, and for collaborating with elected officials, regulators, providers, employers, and other key stakeholders to drive improvements in healthcare access, quality, experience, outcomes, and affordability in Maine. Denise has more than 25 years of diverse experience in the health insurance industry. She started her career at Harvard Pilgrim Healthcare in sales and management. She joined Anthem in 2010 as Director of Sales in New Hampshire, and in 2011, she was promoted to Regional Vice President of Sales for the New Hampshire plan. She holds a bachelor's degree in English from Boston College and a master's degree in business communications from Emerson College. She also holds a certificate from the University of Pennsylvania Wharton School, Finance and Accounting for the Non-Financial Manager Program. Denise, thank you for your sponsorship this morning and welcome.
Good morning. Thank you so much, Peter. Good morning, everyone, and thank you for taking the time to be with us this morning. And thank you also to the Chamber for organizing this forum and bringing us all together. As president of Anthem Blue Cross and Blue Shield here in Maine, I am honored to serve on the board of the Chamber and work with many of you, whether it's through the Chamber or through our customer relationships or through Anthem's work in the community. Anthem, as many of you know, is headquartered in South Portland, and we have nearly 650 employees here in the state of Maine. Having served Mainers for over 84 years, we have a deep understanding of the market and the state of healthcare here in the state. As I'm sure many of you know very well, Maine has some of the highest healthcare costs in the nation. We are also an aging state, meaning that more people will likely need to utilize healthcare services, and has amongst the highest cost burden in the country, meaning the wages to healthcare expense financial burden is higher than in most other states in the nation. There is no question that healthcare affordability is one of the biggest challenges we face as an industry and a nation, and Maine is no exception to that. And while inflation is certainly amplifying this problem, affordability is an issue we've been struggling with for quite some time in Maine. And there are a number of factors impacting that affordability issue. I would argue that one of the biggest factors in being able to control healthcare costs is provider consolidation. And while there are many cases where consolidation is necessary, numerous studies in our experience point to mergers ultimately rising prices in almost all cases. Unfortunately, when healthcare systems are allowed to consolidate and grow their influence, it reduces competition for where care is delivered, raising prices and leaving patients with less choice and less control. This gives health systems leverage over carriers in contract and reimbursement negotiations, and we must maintain adequate networks to ensure that members have access to the services and the care they need. And we are seeing this impact firsthand in Maine. When systems are allowed to get extremely large, their hold on the market gives them great power and leverage when it comes to setting costs for healthcare. And if the cost of healthcare services continues to rise unchecked, all Mainers will pay more for healthcare through higher premiums and higher out-of-pocket costs. We are all managing high inflation costs at home and at our businesses. We all know that. And hospitals and providers need to do so as well. This is a broader conversation we need to have as a state, how we can ensure that there's appropriate oversight over hospital costs and consolidation to protect healthcare affordability for consumers. So what is Anthem doing to help lower costs? In addition to fighting the impacts of consolidation, we're taking a number of steps at Anthem to ensure that healthcare is affordable in Maine, and I'll just touch on just 4 of them this morning. One is value-based care. We are working to accelerate growth in value-based payment models in which providers are rewarded for efficiency, coordination, health outcomes, and patient experience, rather than on the volume of care provided under the traditional fee-for-service system. Second is diversifying care options. We have worked to diversify Maine's healthcare delivery system over the years because while hospitals play a critical role in patient care, it is essential that members have non-hospital-based alternatives for outpatient services, alternatives that have historically been in short supply in our state. One example of our work in this area are the collaborations we have with providers like Convenient MD, Intermed, and others. Number 3 is telehealth. Individuals have grown more comfortable accessing care virtually during the pandemic. We've all seen this. Telehealth is expanding access to care for those in rural areas of Maine and has the potential to address disparities across socioeconomic divides. It's also changing the way behavioral health providers are delivering care. One thing we're working on right now at Anthem is bringing virtual care options to the market. And finally, digital tools. As a payer, we can leverage our data to better serve members and provide personalized healthcare that will deliver better health outcomes and empower customers to make decisions about where they go to get cost-effective care. Also, by using data and technology, we can see advancements like greater use of remote patient monitoring and greater use of tools like clinical sensors and ambient sensing, for example. In closing, there's a lot of change happening in healthcare right now. We all know that. We feel that every day, much of it for the better, but there are still challenges that we need to overcome. At Anthem, we're working to protect our customers and our members from increased costs and to protect affordability for the businesses and the people we serve. But we cannot do this alone. It will take a concerted effort from all players to address the underlying causes of high healthcare costs in our state and to continue the dialogue about these topics. I'm excited to hear from our panelists today, and I look forward to continuing to work with the Chamber and with all of you on ensuring Mainers can continue to access high quality, affordable healthcare right here in Maine. Thanks very much. And I think with that, I'm turning it back over to Peter.
Thank you, Denise. Thank you for your remarks. York, when you talk about change in healthcare, you are absolutely correct. And that's part of what we're going to talk about this morning. Because in February, the Bureau of Insurance made the decision to finally merge the individual and small group markets after more of a year of study. Ostensibly, the move is supposed to create more stable pricing in both the individual and small group health insurance markets starting in 2023. The merger pools the risk of the two markets and rolls small group coverage into the already existing individual reinsurance under the Maine Guaranteed Reinsurance Association. Reinsurance, which has been applied to certain claims in the individual market for a number of years, and by most accounts has been successful, and it is funded through an assessment that is levied against carriers and self-insureds in the amount of at least $4 per member per month. In issuing the order, the Bureau of Insurance estimated pooling the market and the reinsuring the pooled market through Mcgara is expected to result in an average premium reduction in 2023 of approximately 8% for individuals and approximately 6% for small employers, compared to a baseline with separate risk pools and no Mcgara reinsurance program. For 2024, the projected premiums reductions are approximately 6.1% for individuals and approximately 3.9% for small employers. The question remains, is this the correct yardstick to be measuring these reductions? And in fact, because in fact, individual claims have been reinsured through the Mcgara system since 2019. We're here to talk about that this morning, and we have a group of folks who have been involved with this process for quite a while. I'd like to welcome them and introduce them to you. First, Tim Schott, who's the acting superintendent of the Maine Bureau of Insurance. He has been the deputy superintendent of the Bureau since 2009. His responsibilities include supervising the consumer healthcare property and casualty divisions, the market conduct unit, the licensing unit, and the research and statistics unit. Prior to joining the Bureau, Tim served as a criminal prosecutor in Fort Dodge, Iowa for more than 13 years. He prosecuted all levels of crime, including felony drug abuse cases, felony assaults, murder, kidnapping, and sexual abuse cases. He graduated from honors from Drake University Law School, earned a master's in mass communications from Drake University, and graduated cum laude from the University of Southern Maine with a bachelor's degree in business administrations. He is a licensed attorney in the state of Maine and in Iowa. Marty Hooper is the life and health actuary for the Maine Bureau of Insurance. She is the lead actuarial staff member for the superintendent on a wide range of issues relating to healthcare, long-term care insurance, and mandated benefits. Before joining the Bureau in 1992, she worked at Dead River Company in employee benefits. Marty has a BS degree in systems engineering from the University of Virginia. Christine Oskenfort serves as the Senior Governmental Relations Director for Anthem in Maine. Chris represents Anthem before the Maine legislature, before various state agencies, and serves as the company's primary liaison with the policymakers, governor's office, and the Maine Bureau of Insurance. Chris joined Anthem in 2009. She is a graduate of Vassar College and Syracuse University of Law. And prior to joining Anthem, she served here at the Chamber as the Senior Governmental Affairs Specialist for the Maine State Chamber of Commerce. Eric German is president of employee benefits for Cross Insurance. In his position, Eric leads Cross employee benefits to the team throughout New England and the Northeast and provides guidance and support to integral management across his clients. Eric has vast experience in the health insurance space, having worked for Anthem Blue Cross and Blue Shield of Maine for 22 years prior to joining Cross Insurance more than 6 years ago. Eric is licensed in the state of Maine and other states as a life and health producer. He holds a BA in Humanities and Social Sciences from the University of Massachusetts at Dartmouth. We're going to begin our presentations with both Tim and Marty, and thank you very much for joining us this morning.
Tim, I've noticed Marty's trying to get in. I'll keep monitoring that if you want to get started.
Okay. Good morning. Glad to be here, and thank you for the introduction. And I'm hoping Marty is going to join us in a few minutes because she understands some of the technical areas here better than I do. But let me see if I can share my screen. All right, is the share screen working? Hopefully.
Yes, it is.
Okay, great. So to start out, kind of the background, and Marty, if you join, feel free to let me know you're here, but I'm going to try to work through some of these. In 2022, 70,000 residents had health insurance through Maine's individual market. And this has grown substantially, obviously, over the last few years, more than double compared to the pre-ACA enrollment of 32,000 back in 2013. During that same period, the small group enrollment has been going down, as I'm sure many of you are aware. And it's been about a 41% reduction during that same time period. In the individual market, as Peter mentioned, premiums have been decreasing in recent years, largely due to the Mcgara program being reinstituted. And also during that same period, small group premiums have continued to increase. The idea of merging the markets really started with the Made for Maine Health Coverage Act, which was back in 2020. And this was a largely bipartisan, or almost completely bipartisan bill passed back then, because it was pretty widely recognized that the small group market needed some help. And so that's part of where this idea originated, to merge the markets. The Made for Maine Health Coverage Act also did several other things, including moving us to a state-based exchange and introduced clear choice plans. So it was a pretty wide-ranging bill. Part of the merger idea is, of course, tied to what's called a Section 1332 waiver. Every year we get a waiver from the federal government on how we use funds that come back basically from the federal government under the Affordable Care Act. And we've been using those funds for Mcgara, which is the reinsurance for the individual market. And the idea in the merged market is to extend that reinsurance to also cover small group plans. So again, this was authorized by LD 2007. The purpose of it is to stabilize and reduce premiums in both individual and small group markets by providing that reinsurance. Funding is provided by federal funds in addition to an assessment that's made on health plans in the state of Maine, and it's $4 per person per month on all market segments. Another important aspect of this is that Mcgara has changed the reinsurance model from prospective to retrospective.
Hey, Tim, can you hear me? This is Marty.
Yes, great. Glad to hear you.
I will take over and do my best.
Excellent.
I am on the phone.
Okay, we're on. You can see where we are on slide 5.
Yes. Yeah.
Excellent.
I think you can go forward. I think we covered what I would have on that.
Very good.
So then on the next slide, just wanted to mention that we were, with the help of Gorman Actuarial, doing an analysis and projections on the effect of the merged market, and did decide to defer it for another year. So we updated our analysis and targeted it for 2023. So next slide. So to go over the merge market proposal, first, the idea was to merge the small group into the individual market, and that would reduce individual rates, adding more premium tax credits into our reinsurance program, so that then we would extend the reinsurance program to bring in the small group market, and then expected to reduce premiums in both of those markets. So the most recent analysis that was provided in the 1332 waiver projected an 8% compared to baseline for individual market in 2023, and 6% compared to the baseline. In 2024, it's a little bit less. It's about 6% for individual and 4% for small group. And when we talk about the baseline, that's without any reinsurance. And then we're showing the savings by merging the market and extending the reinsurance to both of those markets. Next slide. So I just wanted to mention the American Rescue Plan Act. So ARPA did bring in some more subsidies, and Maine received an additional $8.6 million in the pass-through funds to go towards reinsurance, but those weren't used for 2022 because the rates had already been approved. So that is included in the amount of funds available for the merged market in 2023. And the next slide. So to give you an idea of what this pooled merged market will look like, the same health insurance plans will be offered to individual and small group, but there will be some marketing differences. So we're not asking the carriers to actively market or target necessarily the same plans to both of those. but it is available under the requirements. So there's one risk pool for rating, and that brings in more people. The more people you bring, the larger number it's spread across. So we get more credibility, we get more stability in the market, reduces premiums. So we're hoping to encourage growth in membership. And the reinsurance is expanded to small group to provide stability in that market. The next slide. So to discuss some of the changes to Mcgara, Mcgara started out as a prospective reinsurance model, and that was unique to Maine and Alaska. Other states have used a retrospective model. The retrospective model works better for small group, so we encouraged Mcgara to switch to that, and they did in 2022, preparing for the merged market. So to give you an idea of how the attachment points or the coverage of the reinsurance has changed, I listed they're slightly different, a little bit lower on the attachment point with prospective. Now with our retrospective program, it's 76,000 at 100% to 250. For the merged market, it's fairly similar. I think it's right now we're discussing closer to a 90% up to 275. I'm sorry, 90,000 up to a 275,000, 100% coverage. And then after that point, the responsibility of the health insurer. And why that's important is where the attachment point is set determines how much we receive in pass-through funding. So in our projections for the 1332 waiver, it was projected about 22 million. If we're able to lower the attachment points a little bit due to some surplus in Mcgara and the ARPA funds, we're now looking at it could be closer to 40 million in pass-through funds. Next slide. So the steps for implementing the pooled market, we have proposed and implemented our Rule 856 that lays out the requirements for the merged market. We had a public rate hearing, as we do for our rules. We also had public forums on the 1332 application, submitted it to CMS. CMS determined it was complete and opened up a comment period. We've received those comments. We're working through those for responses and waiting for CMS to make the approval. Now in the regulations or statutes, I'm not sure which, there's a 180-day period of time that CMS has allowed themselves, but we have been in a lot of discussions with CMS, very closely giving them the concepts, provided the analysis. So we are anticipating to receive a response from them within the rate review time period. So I've asked the carriers to submit their filings by the end of June, assuming the merge. Next slide. So the other piece of the merged market is the Clear Choice standardized plans will also apply to small groups. And to give you an idea of the process, we've had our stakeholder meetings, there's been written comments, we've posted the material on the website. There is a regulation also for Clear Choice that lays out requirements, Rule 851, including a bulletin that will finalize that cost share structure for the plans. And then, as I mentioned, at the end of June, we'll receive our filings and review those for approval during the summer. Next slide. This is just an example to give you an idea of what the Clear Choice cost structure looks like. The idea of the Clear Choice plans is to reduce confusion. We're hoping to reduce the number of plans. We've heard from employers that they don't necessarily want to have to read through 21 pages of different plans. So we're studying which plans are the most popular, talking with carriers, and trying to find a way to consolidate the number. We do struggle with AV restrictions. That's a CMS requirement you know, that the actuarial value of a plan to meet the metal level has to fit within a certain number of percentage points. So we're trying to create these clear choice plans with some value to them, benefits that are before deductible, reasonable co-pays. It does need to include state and federal restrictions. We're trying to avoid premium disruptions. So there's a lot involved in creating these plans. And it's not just a one and done either. Each year we'll reevaluate and try to improve them. Okay, next slide. Oh, there, I get to hand it over to Tim.
Thanks, Marty. And I just wanted to mention a little bit about the Small Business Health Insurance Premium Support Program that many of you are probably familiar with. But just as a reminder that that program is still in place, and it runs actually through April of next year. As of this December, it was assisting 5,700 small businesses and over 44,000 covered lives. This was part of Governor Mills' Main Jobs and Recovery Plan Act. And it's funded by $39 million in federal funding from the American Rescue Plan. We, as the Bureau of Insurance, implemented Rule 857 a few months ago, which kind of sets out the parameters for the program. And this is basically how it works. There's a credit based on the subscriber type for each employee that's in a small group plan. And just a couple of reminders, the insurers are providing this credit kind of automatically to small group plans, but it's obviously important that employers let their employees know about the plan, including giving them notice about it. And it's also important to remember that the credit has to be shared with the employee, so it doesn't just go to the employer's payment, it also goes to cover part of the employee's contribution to the premium. So I just wanted to kind of give those two reminders. And our webpage has information about the program, including a calculator that a lot of businesses have used to try to figure out the proper split of that credit with their employee. So it's a good resource, and obviously feel free to contact us if you have any questions about it. And I think that's the end of our presentation.
Thank you very much, Tim. Like I said, we'll hold any questions till we're finished with the rest of the panelists. Christine, the floor is yours.
Okay, can you hear me all right?
We can.
Okay, I'm not going to turn my video on because my internet seems to be freezing intermittently. So
Everybody's got technical issues.
yeah, it's that kind of day. So let me see if I will try to share my screen.
I think Chris may have frozen when she tried to share her screen. Can you hear us, Chris?
Well,
So Pete, if you could unmute my phone, I will speak using that.
Angie, can you do that?
Oh, yep, hang on, her phone. Let me look through the list.
It should be unmuted. I have you unmuted on that.
Let's try this. Did we fix it?
I think she's frozen. Yeah, she dropped out. Eric, how do you feel about?
And notice I jumped back on camera.
I saw you. You were very astute. Thank you.
All right, let's change it up a little bit. So a lot of what I'll speak about was going to jump off of where Christine was, but hang on just a second. All right. Okay, can everyone see my screen?
Looks
Great.
good.
All right. So as Marty and Tim spoke about the merging of the individual and small group markets, I really thought it would be best to focus my discussion on solutions and options that are available for folks specifically in the small group market, but I'll also touch on the large group market. So first, a little word about who Cross is. We were founded in 1954 by Woodrow Cross at his kitchen table. We've grown a touch since then. We have more than 1,000 employees throughout the Northeast, 50 plus locations. Employee benefits, we are in all the New England states and New York. We have more than 15,000 employee benefits clients, more than 100 employee benefits professionals, and we are the largest employee benefits agency in the state of Maine. So the current state of the employee benefits market, it's a very challenging market. Premiums are rising. We are really starting to see the impact of the pandemic, not so much in terms of direct COVID related claims. Those seem to be waning. What we're now seeing are rises in elective surgery spending. Also, preventive care having been put off is leading to later diagnoses of issues that would have been identified through proper preventive care. So, for example, a cancer could have been discovered early and it is being treated later, and it's more expensive, of course. Also, increased regulatory pressures, a very tight labor market. I can see a lot of our clients are on the call today, and I know the pressures that you're all dealing with. Employee retention is of utmost importance. Competitive benefits play a major role in that. And we've also got many clients who are looking for new innovative benefits to differentiate themselves from their competitors as it pertains to hiring. We have a quickly evolving technology landscape in the insurtech space. If I had a nickel for every insurtech startup that contacted me on a daily basis, I'd have an awful lot of nickels. It's a space that is volatile. And one of my roles as president of employee benefits is to vet these solutions on behalf of our clients to see which we think are going to resonate long term. And lastly, the inflationary economy we are living through is putting pressure on employment spending. So you've got a combination of a very tight labor market and an inflationary economy, not a great combination for employers. So impacted markets, as Tim and Marty mentioned, individual and small group are the most impacted, and large group impacted as well, but not specific to the issues that we're discussing today. So alternatives for small group employers, and I'm going to speak about the pros and cons of each. And then once I get through these options, I'm also going to talk about some of the threats that I see that underlie these options. As Peter mentioned, I was 22 years with Anthem Blue Cross and Blue Shield of Maine, and I've been almost 7 years now with Cross. And at the end of the day, I'm an insurance guy, and I grew up in this space, and I care deeply about the health of the market. So I'll talk about the impact that could be seen as a result of some of these options. So small group fully insured. It's what we all think of as quote unquote traditional insurance. It's a community rated product in the under 50 market. That means the health status and claims of the entire community lead to the rate increases. They are the rate increases are brought before the State Bureau of Insurance, who review the request for increase and then approve or deny or work with the carriers. There are multiple carrier options: CHO, Anthem, Aetna, Harvard Pilgrim. Unfortunately, we've not seen, other than the entree of CHO prompted by the ACA, we've not seen a lot of growth in fully insured options. And I do question whether or not we will see others enter. And I should mention United Healthcare. They'd be angry at me if I didn't mention them. Savings are generated through plan design changes, which are, of course, carrier controlled. So you've seen some of the carriers go the narrow network route. Others have gone the tiered network route, where you get the highest level of care at a tier, or a coverage at a tier 1, a lower level at tier 2, and then the lowest level at out of network. The beauty of fully insured environment is it does lead to stable monthly costs as the rates are prompted at renewal, and they stay the same through the course of the plan year. So what we have seen, and really Aetna was the first to market with these products in the small group space. Cigna has actually offered a similar product in the larger group space for many, many years, but Aetna rolled this out quite 7 or 8 years ago. And it's a level funded product. So I think of level funded as self-funding light. So what happens with a level funded product is premiums are developed at max exposure. So if a fully insured premium is considered 100%, either 120 or 125% would be maximum exposure. So the premiums are set based on maximum exposure for claims. So the potential for savings is there when claims are low. Because you're being billed at maximum, your premiums are in fact stable. Then what will happen is at the end of the plan year, and by the way, you do get monthly claims data, so you know the status of your claims going forward. At the end of the plan year, sometime after that, 3 to 6 months after the end of the plan year, you can be eligible for a refund. And that's based on how your plan ran. And depending on the plan design you've chosen, you can be eligible to receive half of that claims differential between what you paid and what was actually paid out, or as much as 100%. But again, it depends on how you set up your plan with your broker. A variety of underwriting methods ranging from medical questionnaires to prescription drug utilization. There's several of the carriers use a vendor that can estimate prescription drug spend. Additionally, there's a niche of carriers out there who have introduced reference-based pricing options on level funded programs. So if you're not familiar with the term reference-based pricing essentially pays claims based on a percent of Medicare. It's widely known that specifically in the state of Maine, commercial insurers pay roughly between 250 and 290% of Medicare. So if Medicare is spending $1, the commercial carriers are spending $250 to $290. I think the actual figure is around $280, but so you can see there's a vast difference between what Medicare and the commercial carriers are paying for claims. What reference-based pricing does is it sets a threshold. So 120, 150, 180% of Medicare. We have not placed a large amount of this business in the state of Maine. I will say in the state of Vermont, my team has had some success with these products. It should be noted that this is not level funded options are not state regulated, as they are in fact self-funded plans. So they do not typically comply with state mandates. And that's really important for employers to understand that that their plans will not comply with state mandates. So it's really imperative that employers and their brokers do a really good job educating employees about some of the pitfalls of level funded options. Now, in the small group market, groups do have the ability to jump back into the small group market, the fully insured market, in the event that their claims don't run particularly well. And I'm sure, you know, I'm just happen to see Ed Fibell, who knows more about health insurance than most people. And I'm thinking he's going, oh, that doesn't sound great for the fully insured market. And that will be one of the threats that I'll talk about in a bit. In addition to level funded options, there are actually self-funded options that are coming down market. Most folks don't really think of self-funding for smaller groups, but there are carriers now and TPAs that are coming down market to as few as 25 employees. There is now. I want to just. Some people hear the phrase self-funded and it sounds scary. On a small group basis, you're not truly self-funded, meaning you're not going to pay all of your claims. You are going to have individual specific reinsurance, and you're also going to have aggregate reinsurance. So the individual specific reinsurance, you're going to pay claims up to some number, maybe it's 20 or 25,000, and then you'll have reinsurance to protect you beyond that. And aggregate reinsurance, similar to the level funded program, anything above 120 or 125% of your expected claims, you're going to have insurance on that. That said, there is less stability in the rates. You're going to see variability in the rates. There is obvious potential for claim savings when claims are low. You do have access to your claims data, fairly robust access, and it also gives you greater flexibility for customization of plans. A variety of underwriting methods, again, especially when you get down to that 25 employee space. We could be talking medical questionnaires. We could be talking an RX vendor. Similar to level funded, it is not regulated by the state of Maine, so benefits are not required to comply with state mandates. We do typically find most of our larger self-funded clients do tend to comply because that potential for member abrasion is they are sensitive to that. And it's also not subject to the 3% premium tax that fully insured carriers are subject to. That also applies on the level funded products. Now we get into Icarus, individual coverage health reimbursement accounts. These are in fact available to groups of all sizes, large group, small group. The Icarus came about through an executive order of President Trump. Now, politically, you might think that the Biden administration would be reluctant to continue an executive order that was signed by President Trump. However, this particular executive order drives enrollment to the exchange-based individual products. So highly unlikely that the Biden administration would do anything to preclude the availability of individual coverage HRAs. So essentially what you're doing with an individual coverage HRA is you are going to give your employees monies that they can then use to buy coverage on the exchange or on exchange or off exchange. There are a number of rules that apply. I will tell you, we have written several of these in the state of Maine and in other states as well. They have been very effective cost-saving tools when appropriate. And I'm giving myself a lot of leeway here, but because the phrase "when appropriate" is pretty loaded. But we have had employers who have really, one particular employer struggled with 30+% increases in the fully insured space over a period of 2 or 3 years, and their premiums had simply become unaffordable. And we investigated an ICRA solution for them, and it worked. It saved them north of $200,000 a year. So again, it's available to all group sizes. It allows employees greater choice because the employees just go to the individual market and they pick the plan that works best for them from an affordability perspective, from a network perspective, from a benefits perspective, and they have the money that their employer has given them that they can use to spend on those products. That said, with employees receiving greater choice, it also reduces employer control. Now, the plans still have to meet ACA affordability requirements for those larger groups that are bound by ACA affordability requirements. So there's a lot of calculation that needs to be done, and our producers assist with those affordability calculations. You can also offer ICRAs to limited populations. There are, in fact, guidelines for the populations that you can break out. So, for example, you could offer an ICRA to part-time employees and keep your traditional coverage with your full-time employees. You can cordon off certain locations for ICRAs. You can union versus non-union, salary versus hourly. There's a number of things you can do to cordon off this ICRA and use it really strategically, which gets to the next bullet point, which it allows for risk mitigation. So, for example, if you have a population that instinctively you think is, perhaps you've got a population that you instinctively think is less healthy than another, you can cordon that off in an ICRA. Again, stealing my next slide, but I think you can see the potential for negative impact on the combined individuals and small group market. But I'll talk about that in a minute. I will tell you, enrollments can be very challenging. Again, my team has done several of these, and the biggest challenge is enrollments, because you've got to do one-on-one conversations with employees to help guide them through the individual products. So now, just like with the level funded products, a small group that offers an ICRA, let's say they offer an ICRA and decide that it didn't work well for them, they can jump back into the fully insured small group space. A large group, however, is going to have difficulty jumping back into fully insured, simply because they're not going to have any claims data to share with the fully insured carriers, because all of their employees are in individual coverage HRAs. So it definitely creates a challenge. A large group should not make the decision to go into an individual coverage HRA thinking that they're going to have a fully insured safety net. They may not. Especially in the large group space, this could negatively impact recruiting efforts. Thinking back to one of my early slides, retention and recruitment in a competitive market are challenging. So this just creates another layer of challenge for you as it pertains to recruiting. It also could impact company culture. I can tell you, one of our larger groups that implemented an ICRA, they just did a masterful job. And frankly, our producer who did it, they did a masterful job prepping the employees. This was an employer that has very, very high employee retention, which actually led to some of their claims challenges, because they don't lose employees. Those employees age. As they age, their medical claims increase. So they did a great job educating their employees about the challenges that they had been facing on the health insurance front. So that made for a really tremendously smooth transition, and the employees bought in to the concepts. But at the end of the day, this really could impact company culture, and that cannot be discounted. So overall, though, as I mentioned, there are some threats that exist for the market, especially for the combined individual and small group market from some of these options I've talked about. So healthy groups could seek the level funded option or self-funded options. So you could see, and we have seen it, I will tell you, we've seen a shift of some of those healthier groups, especially over to the level funded products, not quite as much to a self-funded model. Secondly, risk mitigation techniques can negatively impact overall claims experience of the community rated market. If suddenly we're taking less healthy populations out of the level funded market, or frankly out of the fully insured market, and shoving them into individual and small group, that can create a problem. That's through the Icarus. Certainly could lead to employer and employee confusion. As it stands today, employee has trouble with a claim, they get frustrated, they go into their HR department, and HR department jumps in, they call the broker, they call the carrier, try to help out with the situation. Once you're into an ICRA, that doesn't exist. The HR person is going to say, yeah, call your individual carrier. That's not our contract. Is we have a deal with you, we don't have a deal with the carrier anymore. Additionally, I do have concerns that that this can ultimately lead to the individual and small group fully insured markets becoming less attractive to carriers. So I don't know that we'll see a lot of new fully insured carriers entering the market. I do want to mention there are a couple of, I mentioned technology, and I didn't put together a slide specific to this, but I am pretty excited about a couple of different programs that are coming out. There's actually a local Maine startup called Soul Being that is focused on the holistic health space. So think massage, chiropractic, acupuncture, that kind of thing. And they're a new partner of ours that I'm pretty excited about. And also, you may want to pay attention to a company called Firefly Health. It is they're offering a level funded product that is using, the basis is telehealth based out of Massachusetts, the Boston market, and then back-ended by a network. Pretty exciting, innovative solution. Haven't gotten a lot of traction here in the state of Maine yet, but exciting to talk to. So be sure to speak to your brokers about that option. So with that, I will kick it back to Peter.
Eric, thank you very much for your presentation and your thoughts. I am now going to turn back to Chris, who I know is on and has done some yeoman's work to stabilize her internet connection. And I'll let her have the floor.
Oh, thanks, Peter. My apologies. Not only can I not be on video, but I am unable to send my slides to anybody I can't even access them myself to try to share them with my colleagues to send to you. So my apologies for the technical difficulties, and we will get you the slides so that you can send them out when you send out the meeting materials to everyone. So I know that Tim and Marty touched on this a little bit, but the merger of the individual and small group markets stems from the market reform proposal submitted by Governor Mills in 2020 that authorized the the merger of the individual and small group markets. Originally, that was targeted to occur on January 1st of 2022. And as they noted, carriers would be required to offer the same products to both individuals and small groups. The Maine Guaranteed Access Reinsurance Association, or Mcgara, which reinsures the individual market today, would be expanded to a merged market. And the merger was subject to the requirement that the superintendent find that the average premium rates in both the individual and the small group markets would be the same or lower than they would have been absent a merger of the markets. And it was also subject to a requirement that CMS approve a Section 1332 waiver amendment. It also required the Bureau of Insurance to establish clear choice plan designs for both individual and small group merged market, also beginning 1/1/2022 as originally proposed. And premium rates would not be able to vary based on whether they were issued to an individual or a small group in such a merged market. And as Marty noted, it changed the Mcgara program to be a retrospective model, meaning that carriers no longer needed to identify who was going to be eligible for reinsurance at the time of enrollment. It's strictly based on claims in a more traditional reinsurance model. But as things happen, a lot of unforeseen circumstances occurred and caused some delays. I mean, it was in a rather aggressive timeframe under the legislation under ideal circumstances, but the COVID-19 pandemic obviously created a shift in focus, not only for the Bureau of Insurance, but for carriers as well. And the Gorman actuarial study that was released in August 2020 estimated that small group rates would decrease by 4% if the markets were merged, and individual rates would increase by 4%. But it became clear that the timing just wasn't going to work. So the Bureau delayed implementation of a merged market until potentially 2023. And in 2021, legislation was submitted to formalize that. So LD 1725, which was enacted in 2021, delayed the potential merger of the individual and the small group markets from 2022 to 2023. But it also changed the standard for determining whether the markets would merge. Under LD 2007, the original legislation, the standard was, as I mentioned, whether average premium rates in the individual and small group markets would be the same or lower than they would be absent a merger. But LD 1725 in 2021 changed that standard to whether average individual and small group rates are lower than they would have been absent a merger and absent the Mcgara program, which meant that we weren't, in our view, we weren't comparing apples to apples because it wasn't reflective of the market as it exists today. And it made it very easy to meet the standard for the merger to move forward, because obviously a market with reinsurance is going to have lower premiums than a market without reinsurance, even if it is spread across a larger pool. There were two analyses of the merged market in 2022. The initial Gorman actuarial report that was released in January of 2022 indicated that individual premiums would increase approximately 6% in 2023 and 8% in 2024. Correspondingly, the small group market would see a 6% reduction in small group rates in 2023, and that would be reduced to 4% in 2024. But that analysis didn't predict future enrollment in the individual market under the current scenario, only under a scenario without Mcgara. So the Bureau provided an updated analysis to CMS in March of 2022. And that analysis indicated that individual premium rates would increase by 9.7% in 2023 and 6.7% in 2024, while the small group market would see a 6% reduction in their rates for 2023, and that would be reduced to 4% in 2024. This report also looked at enrollment, and it showed, now, as noted in the slides from the Bureau of Insurance, individual market enrollment is actually higher now than 66,000, but that was the estimate at the time that the report was released. But open enrollment wasn't finished at that point. So in a merged market scenario, the Gorman analysis projects that the individual market will drop to approximately 58,800 in 2025 in a merged market, versus nearly 60,000 in a separate market, while the small group market sees modest benefits in terms of membership, but only a difference of 1,600 members in 2025 when you compare small group membership in a merged market to small group membership in separate markets. And as was noted, the purpose was to reduce premiums in both the individual and the small group markets. Our concern is with the impact on the individual market. As I noted, it's a nearly 10% increase in 2023, and that's without taking into account trend or new mandates that have been enacted that will also impact costs. And nearly 30% of the individual market does not receive a subsidy and will bear the full brunt of that increase. And sole proprietors often buy in the individual market. And we would note that other options were not studied. So, you know, we've had some concerns, and these are well known. We've expressed them repeatedly to the Bureau. But nonetheless, we do expect that the merged market is likely to move forward, and we are preparing for a merged market environment and preparing our products to offer to individuals and small groups alike. And then finally, as the Bureau noted, we are also required to offer clear choice plan designs in a merged market. For 2023, currently there are 20 plan designs proposed, 19 of which would be available to small groups because catastrophic plans cannot be offered to small groups. This will represent a significant change for small groups because non-grandfathered small group plans cannot be renewed unless they are either an alternate plan or comply with one of the clear choice plan designs. So small groups will see some changes in their plan design. And so the Bureau has worked very hard to create a number of different options. So hopefully there will be plans to meet the needs of small groups. But with that, I'd be happy to answer any questions. And again, I apologize for the technical difficulties today.
Thank you, Chris. I do have some questions in the chat box this morning, and I invite others to go ahead and submit them before we move on. One of the first questions, and we always get this, is will slides be available to participants? And the answer to that question is yes, as will a recording of this when we finished. It may be up by the end of the day. If not, it will probably be up within the next 48 hours. The next question is to Tim and Marty. Thanks for your presentation. Is there any discussion of extending the small business premium or premium relief program through the end of 2023 or perhaps beyond?
Hi, Peter. The short answer to that is we haven't had any discussions on it. I appreciate the question from Kevin. I think it's been a good program, but I think we'd be open to seeing if that's a possibility. Obviously, the funding for it would be the big question. My understanding currently is that this was kind of a one-time funding for that program. So that's how it's been designed at the moment. And we've designed it to last through the required 18 months of the program, which would be, like I said, April of 2023. So that's, hopefully that helps.
I was aware it was a one-time funding, and obviously any kind of relief program would require additional funding. Whether that's going to ultimately be available, I'm sure neither you nor any of us really know. The next question is to Eric. I'm interested in your take on the emergence of some P&C carriers in the level funded environment. Do you see that as a positive factor in the environment? And does it give you any pause when non-health related carriers become involved in this level funded market? And then in parentheses, especially in light of the lack of ACA guardrails and those pitfalls that you referenced.
That's a loaded question that I'm happy to answer. The answer is, am I on the one hand, yes, I'm pleased to see competition come into the space. I am. most of the fully insured carriers in the state of Maine, well, actually all of the fully insured carriers in the state of Maine are either currently offering a level funded program or are developing a level funded program. Does it, so on the one hand, yes, I'm pleased that we're going to see increased competition. On the other, yes, I'm very concerned that we have carriers who do not have tremendous expertise in that space offering products. We've had experience here in the state of Maine with workers' comp carriers and whatnot getting into the health space, and that didn't end terribly well. So it does concern me when we see folks without expertise. Now, I'm hopeful that the underwriters that they brought on to do the work have extensive experience in healthcare. But I will tell you, there are many, many of those carriers that we simply don't write that business with because of a lack of comfort at this point.
Okay. A couple of quick questions regarding level funded plans. Are pre-existing conditions, can they be excluded?
No.
They cannot. And I mean, you sort of were asked a question of a legislator actually put the question in, expressing serious concerns about the effect on consumers of level funded plans. So do you think they play a role in all this? Level funded plans can play a role in this in terms of access?
So impact on consumers. Well, I guess I took the question initially because I actually answered it directly. I initially took the question to mean really impact on the market. I do have concerns, as I shared, that I have concerns of the good risk going into these limited self-funded plans and the poor risk staying fully insured. But now that I reread the question, now that you reread it, I'm thinking impact on direct on consumers. Well,
Yes.
There's a downstream impact on consumers in fully insured markets of increasing premiums as a result of good risk coming out of the fully insured market. But there's also an impact, and I will tell you, yes, there is definitely an impact on consumers when if you've been in a fully insured market for a number of years, you become used to the coverage that is mandated by the state of Maine on the fully insured in the fully insured market. So, for example, we have really good chiropractic coverage here in the state of Maine. Well, I can tell you that is one area where the coverage is more limited on those level funded products. So if you're a consumer who has chiropractic needs, there is going to be an impact of moving to the level funded products. And that's why it's really, really important that brokers and employers really understand the downstream impact for employees when they make those changes.
The only other question I've got at this point is one that I'm going to ask myself, and I'm going to ask all four of our panelists this morning this, because it's something the Chamber, I know, has provided comment to the Bureau on, and others may be aware. Obviously, the idea behind the reinsurance mechanism in Mcgara is an important one, and it's provided an important role in stabilizing the individual market. And I think that is in part the idea behind the merger of the two markets to access, so small group claims can have the same access. The ongoing concern that many of our members have is that they are payors of the assessment and they cannot benefit from the reinsurance market themselves. And they are concerned because with this expansion, and I recognize there's a 1332 waiver involved, there's always a concern that there's not enough money. And then will they be assessed even more and have to pay more for a program they cannot access and they cannot benefit from? That is probably the one thing I hear about this more than any other, and it's what we provided comments to the Bureau to that effect. But what are the assurances that some of these self-insured employers have that they're not going to be assessed further on this?
I can be the first one to jump into that if you want. It's, obviously that's a legitimate concern. I can just tell you that right now that's not being planned. The Mcgara board would, could provide more specifics, but the funding and the health of the program is pretty good right now. So I don't see that increasing in that assessment as being anything that they have in mind at the moment. I can, not to speak for them, but that's my understanding.
Anybody else want to jump in?
So Peter, it's Chris. I would just note that, the assessment amount is capped in statute. And there is, while there is the ability to impose a supplemental assessment of $2 per member per month in the event that Mcgara is insolvent, I think they manage pretty closely, and so it would require legislative action to increase the cap.
But not levy the assessment, correct?
I'm not sure I understand what you mean. It's already at $4 per member per month, so they would need legislative action to go higher than that.
Okay. I have one other quick question, and I think it's for Eric. Eric, you mentioned that an employer can segment off high-risk employees and put them under a voucher plan. It looks like it could easily lead to a discrimination suit. Is there legal precedent?
So it really is a matter of how you structurally work the ICRA. We have worked with our ERISA attorney, and we feel confident that we are not running afoul, or our employers are not running afoul of any discrimination issues. Bear in mind that they are still getting an affordable plan. They are still able to get plan designs that are similar to, and in some cases better than, the options available through the traditional employer route. In the instance of the large group that made the switch, they made a wholesale switch for their entire group. So that was there's certainly no discrimination there. But we have had there have been some legal challenges, and I have seen none that have led to discrimination or successful discrimination claims. But from a legal perspective, we're still very early in the offing for ICRAs, but it really comes down to how you structure the ICRA.
All right, Eric, thank you. Thank all, Marty, Tim, Eric, and Christine for their presentations this morning. We're going to jump to the next portion of our forum, and we're going to talk a little bit about universal health care. As many of you know, the Maine Healthcare Action Network, or Maine All Care, had been pursuing the ability to, through the citizens referendum, of putting a universal healthcare ballot measure before the voters. They announced in April, early April, that they are dropping that pursuit, that they're suspending it, that they felt that they would not be able to get the proper number of signatures in time to get it on the ballot. That doesn't mean the issue's gone away. And the legislature in this last legislative session passed LD 1045, sponsored by Representative Brooks in Lewiston, that authorizes the state to pursue universal health care in Maine, provided that the states get the waiver from the federal government to do so. The issue of universal health care has been around for quite a while. It's been discussed in Washington. It was acutely discussed during the passage of the ACA, and various other states have attempted to pass and then implement universal health care. The one closest to us is Vermont. I spent 3 or 4 years and millions of dollars to try and come up with a universal health care plan before abandoning it. I asked my good friend Katie Mahoney, who's the Vice President of Health Policy at the U.S. Chamber, to give us a little bit of an update on universal healthcare, both in Washington and around the country. And in her capacity at the U.S. Chamber, she is responsible for developing, advocating, and publicizing the Chamber's policy on health and works with members of Congress, the administration, and various regulatory agencies to promote the organization's health policy. She has nearly 20 years of healthcare experience in hospital and health plan operations, as well as health policy. She rejoined the Chamber in June of 2010 from the firm of Greenberg Taussig, where she served as the Assistant Director of Health and FDA Business. Previously, she had worked at the Chamber as the Director of Healthcare Policy from 2004 to 2007. She is originally a New Englander from Massachusetts. She graduated cum laude from Vanderbilt University with an undergraduate degree in English literature. She earned a law degree and a master's degree in health administration from Tulane University School of Law and Public Health and Tropical Medicine, respectively. Katie, thank you very much for joining us this morning. Oh, I think she froze.
I think Katie's frozen. Oh, goodness.
This is our day for it.
It sure is. Let me see what I can do on our end.
I'm back. I'm sorry. Just
you
as you
are.
were wrapping up. Hello. Sorry, golly. Wi-Fi 2022. Hashtag something. Angie, I wonder if you could help share my slides for me.
Yes, I'll go ahead and get those started.
Great, thank you. It's a pleasure to talk with you today. Thanks so much, Peter. Always love talking to the Maine Chamber folks. I thought I would start by talking a little bit about the employer-sponsored system and the value that it provides. I heard Eric talking a little bit about Icarus in that regard, and I think one of the things that we highlight at the U.S. Chamber as we push back on efforts to advance additional government expansion in the healthcare space is the value of the employer-sponsored system. Next slide, please. And so one of the things that I think is helpful to think about when we talk about universal coverage is sort of the backdrop about where the majority of Americans get their healthcare coverage, and that is through the employer-sponsored system. Over 158 million Americans get their coverage through their employer, and notably, they really like that. 71% of employees are satisfied with their employer-sponsored coverage, and these statistics go beyond just sort of basic satisfaction to overall value throughout the system in terms of social value, in terms of value that employees feel they receive, in terms of cost savings, and in terms of the strength of the system being put in jeopardy by an advancement of additional government involvement. I'll give you a few more statistics in three categories in terms of the evidence that individuals like their employer-sponsored coverage. 56% of US adults with ESI said that whether or not they like their healthcare coverage is a key factor in deciding to stay at their current job. 46% say health insurance was either a deciding factor or a positive influence in choosing their current job. And in firms that offer coverage, 78% of those that are eligible for benefits take up the firm's offer. So those are some statistics giving some proof to the fact that individuals like their employer-sponsored coverage and that it's key in job selection. It's also key in improved performance. About 86% of employees report improved work performance and lower absentee rates following treatment of depression. 60% of employers found that health benefits help their staff become more productive. And finally, many individuals will choose better benefits over salary increases. Notably, 80% reported that they would choose a job with benefits, even if an identical job offered with better benefits, even if an identical job offered 30% more salary, but no benefits. Health benefits were so important that 46% of those surveyed said that they prefer to have better benefits than a better paycheck. nearly half of employees would forego more pay for a generous health plan. And those are all different statistics from different surveys, but I think they show a consistent preference for the offering of benefits. And lastly, 9 in 10 respondents said they would leave their current job for one with better benefits. Next slide, please. So, where do voters want to see our healthcare system focus, and where do folks want to see advancements made? 64% prefer to build on the current system rather than create a public option, and 66% prefer to build on the current system instead of opening up Medicare. Next slide, please. And as far as real priorities, I think that this slide is particularly telling as we move from the value of ESI to the dangers of government expansion. 63% of voters are really focused on lowering costs, and their main concerns are access, cost, and long-term fiscal impacts of a public option or government expansion. Next slide. And those concerns are valid and couldn't be more important as we consider what's at stake if we lower Medicare eligibility to age 60, or if we expand government involvement through a public option, universal coverage, et cetera. These statistics speak to the areas that voters are concerned about in terms of exploding the federal deficit and the fiscal impact that a Medicare buy-in or Medicare eligibility modification could have. They speak to access concerns in terms of the lower reimbursements that providers are going to suffer with the expansion of a Medicare population, and the increase in costs in terms of more than a third of those covered under the Affordable Care Act marketplace would see premiums and out-of-pockets increase. So, I think this slide and the prior slide are really, really important as we think about what are voters most concerned about and what is likely to happen with an expansion of a government program. Next slide, please. And this is the last slide, and I look forward to answering your questions, but I think as Peter noted, many different states, almost half of our states, are considering different ways to expand government involvement in healthcare coverage, whether that's through a Medicare for All system in Arizona, whether that is through a Medicaid buy-in option in Florida, where individuals between 16 and 64 that are disabled could buy into Medicaid, whether that's a single payer health system in Hawaii, whether that's looking at a public option in Minnesota. There are all sorts of different names for these government expansion initiatives, and they all have sort of questionable results and uncertainty, frankly, in terms of how disruptive they're going to be to the current system. There are a lot of states currently talking about bridge health plans, which are targeted on those individuals that have been enrolled in Medicaid during the public health emergency and trying to provide a kind of soft landing, if you will, after the public health emergency concludes, and those individuals may have to be reconciled off of a Medicaid enrollment program. And so I think that presents a unique vulnerability at this particular time with regard to additional efforts at the state level in expanding the government role in healthcare with this kind of transition point in the near future, as we're looking at the public health emergency likely ending at this point in October, given that there will be a 90-day notice that is given when the public health emergency will not be renewed, and we have not seen that, and so expect it to be continued beyond the July deadline at this particular point. So let me stop there and take questions. I think I have a document I will have to check and see if I can share it that further details these different 24 state proposals. Some of them have sort of died a death at the moment, but may be resurrected in the future. The most notable, I think, is with regard to Oregon and their Medicaid Bridge program. So with that, I'll turn to the last slide, which is just a question slide, and see if I can answer some questions before we wrap up.
Katie, I only have one question at this point. Hawaii's 1974 Prepaid Healthcare Act can be argued to be a success. Hawaii annually receives top scores for healthcare access, healthcare quality, and public health. Only 5.5% of adults in the state are uninsured. What are your thoughts?
So I'm not by no means an expert on the Hawaii program. I'd be happy to do a little bit of digging and get back to that person or have a sidebar conversation about it. I think, there are a number of different states that have expanded government involvement in healthcare, and for true believers that think that that's the way to go. I think, again, folks can point to the successes of the employer-sponsored system and what we see there. And I'd be interested to see what crowd out or what implications that program in Hawaii has had on the employer-sponsored system.
I just remember in my time at the Chamber, I was involved with the first discussion of universal health care in Maine, the Keller Commission. I believe that was in Maine. It was 1995 and 96. And the estimated cost was about $6.5 billion at the time. The fiscal note associated with 1045 recently, and this is, albeit 95 to 2022, it's 22 years, but is $10.9 billion. So that's a staggering increase in costs to provide a single universal healthcare coverage. But again, as I started this out, folks I believe, intend to come back and seek the necessary number of signatures to put this on the ballot. So I would say this issue and this debate is not over in this state, as is probably the case in other states that are considering it. Katie, I know you need to go, and I want to respect that. And also thank you very much for your time this morning. I really appreciate it. And that pretty much that does wrap up our program this morning. Before we finish, I would like to thank our panelists, our presenters this morning for an interesting and an informative healthcare discussion. I also want to thank our sponsors. Again, our premier sponsor, Anthem Blue Cross Blue Shield in Maine, our principal sponsor, Harvard Pilgrim Healthcare, our program sponsors across insurance in Maine Health and Work Health, and our supporting sponsors are AmeriHealth, Central Maine Healthcare, Martins Point, and Maine Primary Care Association. Thank you to you all. Thank you for joining us this morning. We hope you found it interesting, and we look forward to doing something similar again very soon, maybe without the technical challenges. Have a great day, everybody.
Thanks, Peter.